Please take your seat if you can. Director Foxhoven, if you want to find your way to the other end, I appreciate it. I'd like to ask my secretary to take the roll.
Senator Sidler.
Here.
Senator Costello. Here. Senator Mathis. Here. Senator Goldcover. Senator Chapman.
Excused until you arrive.
Senator Shelton.
Excused until you arrive.
Senator Garrett.
Here.
Senator Green.
Here.
Senator Gilpin.
Here.
Senator C. Johnson.
Here.
Senator Kernbach.
Here.
Senator Reagan. Here. Senator Shipley.
Here. All those that are present will be excused until they arrive. If everybody get the minutes, you should have received them electronically. And there will be a motion to approve the minutes. Been moved. All in favor say aye.
Aye.
Opposed, same sign. Motion carries. Today we have a little extra business to take care of. You should have before you a list of all the bills that are alive at the current time. And also, the smaller sheet of the two is the current bills that are in subcommittee. Those are for your information and for your approval. So unanimous consent, I go ahead and approve those being handed down. I'd like to go and introduce our speaker next. Jerry R. Foxhoven became the director of the Iowa Department of Human Services in June of 2017. Foxhoven began practicing law in 1977 with a strong emphasis on trial practice in criminal and civil law. He also extensively involved in juvenile and family law cases until 2000 when he began as administrator, or he began as administrator of the Iowa Child Advocacy Board. In this role, he was responsible for developing and implementing personnel policies, strategic planning, and public policy advocacy. While in this position, he was also director of two separate child welfare advocacy programs, the court-appointed special advocates, better known as CASA workers, and the Iowa Citizens for Foster Care Review Board programs. In 2006, Foxhoven became director of the Joan and Lyle Middleton Center for Children's Rights, a state and national advocacy center focusing on children's rights issues. Around the same time, he joined Drake Law School as a clinical professor. He instructed juvenile law for third-year law students in the clinical setting, supervising students in juvenile court proceedings and in the legislative practice program as they drafted bills and lobbied for passage of bills pertaining to issues involving youth. Most recently, Foxhoven served as executive director of clinical programs and professor of law at Drake University School of Law. There he supervised a number of administrative responsibilities relating to the school. Foxhoven has authored a number of articles and given hundreds of presentations throughout Iowa and the country. He graduated summa cum laude from Morningside College in 1974, and he earned his Juris Doctorate from Drake University Law School in 1977. He lives in Clyde with his wife, Julie. Welcome, Director Foxhoven.
Thanks. It's a pleasure to be here.
I guess you know what you're talking about. So you have the floor, sir.
Thanks very much. I guess I should push this button so you can hear me better. Thanks.
That's good.
You know, first of all, I want to tell you that it's a real honor to be director of the Department of Human Services. I know a lot of people say, "What are you, nuts?" Because there's always something going on, which is actually one of the reasons I like it. But another is that we help an awful lot of people. Frankly, about a third of all Iowans are, in one way or another, clients of the Department of Human Services directly. That's a lot, over 1 million unduplicated people, and those are the people that in many ways are struggling, you know, to survive and to do well. We manage the Medicaid program, which is a quarter of all Iowans are involved with, over 500,000 Iowans. Some of our most fragile people as well. And I see us, the Department of Human Services, as really having a dual role. One is that we provide a safety net, and the other is that we provide a ladder for people to get to success. And we focus on both of those really pretty strongly. I thought I knew a lot about the Department of Human Services before I came here because I've been working with them for 3 decades in one way or another, mostly on children's issues, mental health issues, but we do an awful lot beyond what most people realize, and I won't even get into all of that today. But I want to tell you how strongly I do feel about this, and that is that we really have a terrific force that work for the Department of Human Services. Every place I go, I try to emphasize I am really blessed with over 4,000 wonderful people who work really hard every day to do the right thing. And it's a real honor to lead them. That's one of the reasons I tell you it's an honor for me to be director of the Department of Human Services. I'm leading a great group of people who work hard, care a lot, and try to do a really good job every day, and they do, 99.9% of the time. They do a terrific job in everything they do. And so that's really the honor I have. I think a big piece of what I've done as I've come here at the beginning is to try to raise morale of those 4,000 some people because, frankly, you know, it's not news to save a life today or to put a family back together today or for people to get the services that they need. The news is when it doesn't work as well as we want it to work or we think it should work. And so as a result of that, those 4,000 people that work for me over and over again, you know, basically feel like they get a kick in the pants because they work hard, try to do good things. They do hundreds of good things a day, and if one thing goes wrong, that's the one that everybody notices. So, you know, I just want to publicly say to all of you what a pleasure it is, what an honor it is for me to lead that group. It's a terrific group. And those of you, I know a lot of you work directly with some social workers. If you do, tell them thanks, because it's a pretty thankless job. One of the things I've done to try to raise that morale, and I can talk about some kind of specific issues across the board for DHS, but one of the things I've done is try to get out in the field and talk to them individually and in groups. That's not something that they're used to, and that's not a reflection of the previous director. It's a reflection of all the previous directors. Frankly, the culture at DHS has not been to go out and hear from the people actually doing the work and saying, how's your life going, what are you doing, and what can we do to make your life better? I've really made that a goal of mine, and I've met with groups of social workers in groups, those that wanted to meet with me personally. I've been meeting with them personally and receiving really a lot of great input as to what we can do to help them do a better job. And I think we've learned a lot, and we're making a lot of changes in the child welfare arena to try to make that go better. The biggest thing that I can just tell you is that you probably have noticed little things from the state office. Those of you that are at this table, I'm sure in the past, if you've called over to the director, to the Department of Human Services and said, I'll use an example, how many kids do we have that get a subsidized adoption? It's about 9,000 of them. You used to get a response, we'll get back to you on that, and about 2 weeks later, you'd get a letter that was signed by the director or signed by somebody in authority that told you it was about 9,000. That letter would have been looked at by 3 or 4 people before it went out to you. Today, if you called and asked how many there were, somebody would, when it's something that simple, somebody would tell you 9,000. It's on the website, we'll send you a link as to where it is. That is not only so that we can be more responsive to you, which we try to be, but it's also because that takes a lot of people out of that loop so that they have time to do the other important work that they have to do. And that's the kind of thing we're trying to do with social workers as well. We're finding out that there's a lot of things that social workers need their supervisors to sign off on today or have needed to, that we need to get off their plate. And that's some of the kind of things that we've been doing, looking at what tools do we need, what do they need, and what can we get off of their plate. I am kind of almost a diagnosable optimist. You know, it's almost to the point of a mental condition. I really see the glass not only as half full, but I'm delighted to have that full. And I can just tell you that I think in today's world, in many ways, I think we're in a perfect position for us to really take a good look at DHS and say, what can we, right now, when we're in an environment where there isn't any extra money, and better days are ahead, we know that. Right now, what can we do to improve what we're doing, get stuff off of our workers' plates, get what we're doing perfected a little better so that when things are better, we can make rational decisions about how to respond when there is more money available. So right now, as I meet with social workers, what I told them from the very beginning is, we can't hire a whole bunch of more social workers. There isn't extra money right now, but we can make your life more livable. And I think they would tell you that we have already, and that we are doing that, and that we're hearing them, and that we're changing some things. And so I can just tell you this, that I think we're turning the corner. I think we've got better days ahead, but I think we've had good days. You just haven't heard about them. Our workers make tough decisions every day, and I think they make darn good decisions. We place kids with relatives really quite often, and that's really good. So I'm proud of what we do in the child welfare arena. Is it perfect? It's not perfect. If you ask me, can we guarantee that no kid that's ever come to our attention will die again, I would say no. We can't guarantee that. We have a president who walks around with probably 25 people with little earphones in their ears, surrounding him every place he goes, and they couldn't guarantee you that he would be safe. We can't guarantee the safety of every kid. We can guarantee that we will do the best we can to make this a safe environment and still respect the integrity of families and try to keep families together when we can keep them together. And we do a really good job of that. Besides just meeting with social workers, which I do virtually every day, we're meeting with both providers. I'm out talking to providers, people who provide the services to our families and children, and even medical services through Medicaid and mental health services. I'm out seeing them to try to see what can we do that we can do a better job of what we're doing. I'm never satisfied with where we are. We can always do better. And I've also even met today, the last time I met with youth was this morning at about 10:30, to say youth that have been in foster care about what can we do better. And they're giving us great ideas that you would say, yeah, this makes a lot of sense, and why can't we do it? So I can tell you that I think we're doing a really good job of stepping back and not just looking at a high level, but also looking at a direct level of the people doing the work. Now, probably what you guys want to hear a lot about is managed care. And so I'll come here and try to give you a little bit of an idea of what's going on in managed care. The first thing, as you know, I came in 7 months ago now. Time has flown. I think today is, the 7th month, exactly. I think I came in on the 17th. And so it's been 7 months. And just to tell you what the pattern had been in Iowa before, and I think which is true in a lot of other states, is that it was more reactive than it was proactive, that we had not even started negotiating contracts with the MCOs at that point. The contracts were technically running out on July 1st. Some states would go as long as into April before they negotiate a contract that was from the previous July. That's just not where I wanted to be, and so we moved forward with contracts about as soon as possible. And I think handled that really quite well. We're committed to, we've hired a new Medicaid director, Mike Randall. Most of you probably have met him. If you haven't, you will soon. He's going to come out and talk to all of you and kind of give you an idea of really how managed care works and so forth, and so that you have a better understanding of it and kind of what his vision is for it. But I just want to say this, that some people say, Jerry, you're looking at everything through rose-colored glasses because all you see is how well it works, how well managed care works. And that certainly isn't true. If you'd sit in my office and see how often I address issues where people raise them and we try to fix them, many of you know that because many of you have sent people to me and we've addressed it directly, worked with the MCOs and tried to do it. But one of the things I will tell you is I want you to keep a few things in mind. First of all, that in Medicaid we serve about 500,000 people, a lot of them with very complex needs. And so most of you are in the business world, some of you entrepreneurs, and I want you to just put this little cap on for a minute. Imagine if you started a business today that had a $5 billion budget and had 500,000 serious people that you work with every day, customers, and worked with all the providers. And if you would think that in 20 months everything would be so seamless and perfect that it would be incredible, I think you'd know better. Are there mistakes? Have there been problems? There certainly have. And I'm not looking through it solely at rose-colored glasses. It has been remarkable how well it has worked with that size and with the number of people and the complex needs and the size of this program. It's been remarkable that it's worked so well in 20 months. Frankly, when it first started, if you'd have asked me what do you think it would be like in a couple of years, I'd have said, still it's going to be chaos. It'll be chaos for a while. We're not at chaos at all. And I think the best reflection of that is that we've had one of our MCOs withdraw from the state of Iowa, AmeriHealth Caritas. We're talking about approximately 200,000 patients, many of them with complex needs. And I know a lot of you heard people say the sky is going to fall and it's going to be the end of the world. It went remarkably well in 30 days to transfer 200,000 patients over from one place to another. Most of the concerns I had were concerns of, this is what I'm afraid will happen, not this is what has happened. Did it work absolutely perfectly? No, but considering the volume, it was remarkable. We had people working on the holiday, on Thanksgiving, and so forth, to really make it work. The system has really worked quite well. What does the future look like? I don't think there's any question that managed care is the future. That most states are going to managed care. This is not uncommon. Most states have early in their program struggled with some issues, some of the same issues that we've struggled with. But I'm going to talk about a couple of those issues today and what we anticipate we're going to do about them and what we are doing about them to try to make it work as well as it can work. But what I want to make sure I emphasize to you is that every time I look at our Medicaid program and our managed care program, and I try to think about what should we do and how do we make this work best, what I'm most concerned about as I meet with patients and as I talk to families of patients, we're in a world today where sometimes you'll hear people talk about a child they had that they thought would live until they were 3 and now they're 30. And you know what the odds are? They're still going to be here when they're 60, and I'll be glad they are. I'm glad that we're able to make people live a long time, even with complex needs, but we need to be there for that person. And we will be there for that person if we make sure that our system is sustainable. And that's what managed care is all about, is to be able to say, we don't want to just be here a year from now or 2 years from now. We want to make sure that 10 years from now, 20 years from now, those people that are relying on Medicaid, if they still need us, that we're still there, that we can still afford to do it for them. And so that's what our focus has been. It's been twofold: to make sure that the people get their needs met, our patients, and number two, that it's sustainable, that we make sure that we have a sustainable system. And every day that's what I work on. When we hear issues from people that say, I'm not getting the care I need, we drill down and try to find out, is it a systemic problem, is it an individual problem, what can we do to fix it, and we do try to fix it. So I would tell you that I have great hopes. We hired Mike Randall as the new Medicaid director. He's committed to, he will be negotiating contracts almost immediately. That, you know, when I hired him, I told him that my direction to him was really primarily, we need a contract before the legislature goes home, so you know what it's going to cost, so that you know what it's going to take to do it. I also said we need to be committed to both of those two things, patient care and sustainability in the long term, that's what we really have to look at. He's committed to that just as I am. And so I think we're on the right path, and we will get there. Will there be things that we need to change or fix? Yeah, there will be. And I think probably you're hearing a lot about integrated health homes, right? And that's really been a serious conversation. We are having serious conversations about them. If I could be real frank about that, and I will be real frank with you about that, we're trying to see what we can. We are meeting every day. I last met between meetings with legislators this morning and other meetings, and this meeting today with our director and my deputy director, Mickey Steer, who was previously the Medicaid director, about what are we going to do about integrated health homes, how do we move that in the right direction. What I can tell you is this, that we initially created these integrated health homes, and I think a number of them stepped up and really did a great job, built it, they're great structures, and they're doing really great work. We have, I think, 36 or 37 of them that are out there, and I think there's 6 or 7 that are really meeting all the standards that we need to meet, and a lot of them that aren't. And so I think what we're committed to doing is our director will be working with both with the MCOs and with those integrated health homes to make sure a couple of things happen. Number one, that we don't throw out the ones that are working well because of ones that don't work well. Number two, that we really evaluate what's going well and what isn't going well, and either get them there to make sure they meet the needs, or have them know that then they're going to be replaced internally by the MCOs, and if the MCOs are going to replace that and do that in-house, that we hold them accountable to make sure that they meet those standards. They should, those integrated health homes should have been held accountable all along. And many of them have not been, obviously, because they've not met the standards that they were required to meet. And so we're trying to be in the process of fixing that. We know that communication wasn't very good from the MCOs to begin with, but we're working every day to try to minimize the damage that people felt when there was this initial response of let's do this in-house for the MCOs rather than externally. Finally, let me say this about, I know there's been some discussion in the news, and I think the governor's indicated that she'd met with me and with Director Randall to discuss appeals. And she has, and we are taking a look at the appeals to see exactly where they are. One of the things I think, and we'll look at all of those individually, now that we know them individually, we'll take a look at those. There are 2 types of appeals that happen. Initially, appeals can oftentimes go internally through the MCOs. If you think about in your own insurance policy, for instance, if your doctor thinks that you need something done and the insurance company doesn't think it's medically necessary, what happens? Just think about what happens with your own insurance company. They have an internal review. That's what they do. The same thing that we're doing basically on Medicaid. And so you have an internal review, you can have a disagreement with your doctor and their doctor, and they get together to do what they call peer review, and they make a determination of whether or not the claim should be paid and whether it should be sustained. We have another step in Iowa when it's Medicaid, because it's a state program, and you can also file an administrative appeal if you're not successful in that internal review. So that actually is, and I think it's a good thing, that actually is an opportunity to make sure that people get what they're supposed to get, and that we have a chance to monitor it. And that administrative appeal comes all the way through, actually to me, ultimately in the end. And so we are able to monitor it. So if you look at the number of appeals and you think about several hundred appeals, and you think about the fact that there are 500,000 patients that are covered by Medicaid, so you are literally talking about millions of claims with a couple of hundred appeals, which is, again, kind of almost astounding that it isn't any worse than that. Now, let me say this, that the people who need to appeal, if they need the care, and they should get the care, that's important. And we shouldn't just say, well, it's only a couple hundred people, it doesn't really matter. It does matter, and we want to be concerned about every one of them. But I can tell you that, again, if you look at the program as a whole, we're really doing quite well. And we will continue to fix what needs to be fixed, and that's my commitment to you. And that was Mike Randall's commitment to me. So I guess that's kind of concludes what I initially wanted to tell you. If you have questions or if you want other areas of DHS that you want me to talk about, I'd be happy to do so.
Thank you, Director. We have probably about a half hour for questions now, and first on the docket is Senator Shelburne, and after that, Senator Garrett.
Thank you, Mr. Chair. And thank you, Director Foxhoven, for being here. I appreciate spending the time to let us know what's happening. Also, I had a chance to listen to Director Randall when we were on the MCO oversight part of it. And one of the things that struck me, and I don't remember if it was you or Director Randall who mentioned this, is that the professional code of conduct, where we expect businesses to interact with each other, was a priority. I would love for the department either to go into detail, in writing. I know we have limited amount of time here. Love to understand what that entails, what the professional code of conduct expectations are. I know in business, my expectation is that if I make an agreement to provide a service, it will be paid for in a timely manner. That if it's not paid for in a timely manner, for instance, there will be penalties associated with that, and there will be a process by which I can get paid appropriately. I would expect that I will have fair notice and fair time frames if there's a change in expectations. I'm not, because these contracts between the MCOs and the providers are for the most part confidential, there's very little opportunity we have as a legislature to understand what these contracts are, but I would expect that the department would at least expect these contracts to be consistent, where you don't have two similar providers working with the same MCO but have massively different expectations in their contracts. What is the department, is there current policy associated with that? And if not, is there a recommendation by the department on how that can be dealt with?
Sure, thank you. Well, first of all, the contracts we have with the MCOs are not confidential. We don't negotiate with an audience, but once they sign them, they're not. The contracts that the MCOs have with their providers are between them. And so it's very much like, again, if I use a reference to your insurance company, each of your insurance, if you all have different insurance companies, they have contracts with providers, with hospitals, with doctors, that we don't have a right to look at either, and nobody can interfere with those contracts, but they have different expectations for them and different payment rates for them and so forth. And that's really what happens with Medicaid as well. Each of the MCOs have contracts with all of the providers that are in their network, and they make agreements as to what they're going to pay them and what the expectations are. I will tell you that we have clear expectations as to what services are covered and what are not covered. I've made real clear to both the people who are advocating with coverage problem. For instance, we had a meeting earlier this week about an issue about a program and whether or not Medicaid should be covering this and is it going to cover this. And my questions were initially, is that service covered right now? It was something that we were going to add, and there were some tops and bottoms that was on some opioid treatment. And I said, is that service covered by Medicaid right now? Is it a payment issue, or it is not a covered service? And the issue is, it seems like it's a payment issue. If it's a payment issue, that's something that Director Randall and I will work directly with the MCOs and get them in line and make them make the payments. If it's not a payment issue, if it's an issue that's something that's not covered by Medicaid today, and if we all agree it should be, then we need to pay for it. Then we need to figure out what will it cost to add that service and how much money do we add into it to do that. And so I would tell you that, again, there was some criticism in the paper, for instance, that we had levied some fines on the MCOs, and I thought, well, wouldn't it be a bad sign if we didn't? It would show no oversight at all. What it really means is we're holding them accountable. And when I came in, claims were very delayed, very delayed. The number one, as I went out and talked to providers, the number one complaint they had was, we're not getting paid in a timely manner. And people heard me say over and over again to the MCOs, and I'd say it publicly, you know what? We pay you on time every month. We expect you to pay our providers on time every month. That has improved greatly in terms of current services. I really believe that once we got them there, that would fix the problem. There are still old claims that haven't gotten paid in a timely manner. So we're focusing on that now as well, to say you need to get those old claims paid so that we can get fresh. And I think Director Randall is well aware that that's a priority for me, is to get that straightened out.
Well, I do appreciate your words on that, because I can tell you that I believe that the department is doing a good job. I think that the contracts between the department and the MCOs themselves are relatively transparent. But because we have a breakdown in the contracts between the MCOs and the providers, I think that makes the department look bad. I think there should be some brackets that we as a legislature define on what good business relations are, so that those contracts that are confidential fall within those good business relations. And it concerned me greatly when the providers, the integrated health homes, were told after the fact that changes were going to be made. I would expect that anyone who I worked with in my business, if they were making a change to the expectations, they would tell me that in the future this is going to happen, and not that, oh, by the way, it happened 2 weeks ago. I would expect that I would be able to get a hold of somebody when I called and said I have a concern, I'd like to have my questions answered. And I would be able to get a hold of somebody who was knowledgeable in that area. Those are the things that I look at and say, clearly there's a breakdown in the professional relationship between the MCOs and the actual suppliers of the services in the state of Iowa, who traditionally have done a great job for the citizens of Iowa. Because of that, I think the department looks bad. And so I would say it's incumbent upon the legislature and the departments to make sure that those contracts are fair. Thank you.
I appreciate that, and I will tell you that that happened almost immediately when Mike Randall came, and I worked with him very closely to be very strong with the MCOs about that was a terrible communication issue. And not only did those providers hear about that after the fact, I heard about it from a provider, not from the MCO. And that concerns me just as much as it concerned you. And I think we're dealing with that issue.
Thank you.
Thank you, Senator Shelburne. Next up would be Senator Garrett with the next question.
Thank you, and thank you for appearing here before us. I think this is something that it's high time that we have a meeting like this. I've heard several people advocate that we just scrap the whole MCO system, go back to the old system. And I'm wondering, do you have any estimates of the costs under the old system versus what you're doing now, and what it might cost us if we were to actually do that? Have you looked into that?
Director Randall is looking into that right now. Because somebody else has asked him the same question, what would it cost to go back to that? I like to say a couple of things about that. First of all, right now we don't have the infrastructure to do it anymore. Those people that, when we did fleet for services for DHS, right now we on a temporary basis are doing it for 10,000 people. That's a very temporary basis. That's not 500,000 people. We don't have the infrastructure to do it today. Secondly, I don't believe it is would be cost effective, and Director Randall will get you those numbers. But thirdly, and even more importantly, as I told you, our number one concern is always services for the individuals. We have put our members at some tremendous change because of AmeriHealth, Caritas leaving our market. And so we took 200,000 patients and moved them from one carrier to another. Some of them had the same changed case managers. A lot of them got to keep the same case managers. That was a tremendous change for them. I think it would be incredibly unfair to the patients to say, and now we're going to take that system and change it again to you. It would, just as I told you, it's been remarkable that we are where we are in 20 months. It'd be another 20 months of really some chaos that would be very hard on our patients if we went back. The last thing I'll tell you is that this is the way of the future. This is the way other states go because they know it's not necessarily sustainable. And I think we all know, if we're all being real candid, that the federal government probably is not going to continue financing Medicaid the same way in the future at some point that they're financing it today, because they're seeing their cost really go pretty high as well. And so we have to be prepared for how do we make this sustainable in the long term. Again, those same patients that we're caring for today, I want to make sure we're there for them 10 years from now.
And I have another question too. I gathered from your presentation that your view is that complaints and problems are diminishing over time. I wonder, can you give us any numbers to illustrate that? In other words, what kind of complaints were we getting 6 months ago, a year ago, as compared to now, so we have something more than just a general statement.
We're hoping better. Yeah, we're hoping to get there. I think it's difficult right now because when we look at, if you just look at total number of complaints, it would be difficult to figure out what would you consider to be a complaint and what would I. And part of that is, for instance, I had one person who called me after AmeriHealth left and said, I have a different case manager, and I thought, gee, I thought that United was going to pick up the case managers. And so I called United and checked, and they had the same case manager. They'd hired that same case manager. I called the patient back, and they said, well, yeah, but she retired. Well, I guess I wouldn't count that as a complaint. But she did initially, and so I'm not sure how we get to that. There are complaints, and I think there will always be. even if we do it, but we'll try to start measuring those better. We do try to measure, and the federal government requires this. I keep wanting to call it CHAPS, but it's actually CAHPS instead of CHAPS. But it's a system where they use third parties. The MCOs have to contract with third parties to go out and measure satisfaction by patients and so forth. And in Iowa, we have all in that at the last report we had the 3 MCOs. All 3 of them on every measure exceeded the national average, the national satisfaction average on every one of the measures. And so we know that generally, by and large, it's going reasonably well. Any one problem isn't good, and we want to fix it. And so we'll try to address them individually, either Director Randall or I. I get involved in some of them. Director Randall does. We always drill down to find out, is it something that makes sense or not?
Well, did I misunderstand? I thought in your presentation you were saying that things are noticeably getting better. Is that right or not?
Yeah, I think they are. I think they are getting better, and I think that they will continue to get better. With our new director, I think it will be helpful. I think certainly payments got better in terms of current payments got better. They haven't for those late payments, those older payments from 2016. That needs to improve yet. There are still other issues like that we need to improve. I think we need to work on some pre-authorization requirements. And so one of the things that Director Randall is committed to doing is, like in the next 60 days, is to begin a process where he will bring in all of the provider groups, people that are providing the services to our patients, along with the MCOs, and they're going to really work in terms of trying to identify what are all the issues that we need to resolve, whether it's payment, whether it's pre-authorization, whether it's just something not being covered or lack of communication, and try to figure out what all of those problems are, and then break into work groups to solve them. And he's really committed to doing that and getting those things resolved. I think it will be successful because I think those providers know more than somebody else, more than the MCOs and more than we do as to what the problems are. And I think that if we all get our heads together and get providers in a room, the MCOs in a room, and the state in a room, and really work hard to identify what the problems are and how to solve them, we'll get them solved. Okay,
well, I know other people probably got questions. I'm kind of surprised that you can't give us anything more than just a general statement that, yeah, things are getting better, but no, even an estimate as to, what's happening in terms of complaints, however you want to define that.
Yeah, so
time's gone by.
I'm not sure how you define it. I think if you read, for instance, the article from the Register about the appeals, while they don't say it in bold print, there were more appeals when we were in fee-for-services before managed care than there are now. And we have a lot more patients now, a lot more patients because of the expansion population. And so, whether you want to use that for a measure, but we have fewer appeals now than we had under fee-for-services when we had lots fewer patients. And so, again, we're not happy when there's any problems with people not getting care. But to your question, I think Director Randall is working on getting a handle, being able to come up with some kind of number and trend to kind of show you where we are.
Thank you.
Thank you, Senator Garrett. Next up is Senator Bolcom has a question.
Thank you, Mr. Chairman. Mr. Foxhoven, thanks for being here.
Sure.
Since December, to your point, Senator Garrett, since December we've been really busy. We've had AmeriHealth leave the state. We've had new tiered rates go into effect. We've learned that integrated health homes, where people are going to be taken away from their care coordinator into another system. I got an email 2 days ago in Johnson County. There's 300 people we continue to case manage for AmeriHealth that in the next 10 days are going to be transitioned over to, so that it's not even done, and it's pretty rough for these 300 people that are going to have new case managers. We have this appeals process mess. People still aren't being paid. I don't know what your email looks like, Senator Garrett, but mine's really, really busy over the last 2 months. So that's my barometer of how things are going. And So things are still pretty rough, and I don't know if they're in chaos or not. For some people, they're in chaos, and so that's a concern. It seems like we've abdicated our responsibility some days as a state to keeping the pressure on these MCOs about our expectations to care for folks. And this contract that we've negotiated, these contracts, really decide kind of how things are going to go down. And sometimes I feel like the department is kind of on the sidelines, and we're left dealing with the MCOs directly, trying to figure out what's been agreed to, what the provider contracts are with the MCOs. So I'm hopeful that from your comments today that you're going to be a little bit more actively involved, and our new Medicaid director is as well, on behalf of taxpayers and the people of Iowa.
I think you can rest assured of that, and I think the MCOs would tell you that they feel pressure from both of us, from both Director Randall.
One of the things the legislature did that costs the state money, Senator Garrett, and I know you're concerned about money, is we dismantled the family planning system we had in place, the services for women and men for family planning, and we were getting about $3 million in federal money that we said, we don't need that money, let's create our own system, when we decided to unfund the Planned Parenthood clinics. I know there's been a request about this, but I'm interested in knowing today, after 6 months of this experiment that the Republicans brought about, how things are going, how many providers are engaged, how many consumers have gotten services, how much has been billed, so we can look back and compare that to what was really quite effective, not only for the patients but also for taxpayers, the way we did family planning services. Do you have anything to report on that today, and when can we expect some information so we can see how that's working?
You know, we're still not getting, even all the billings are in yet, and so it's hard to give any kind of accurate number right now until all the providers do billings and we get clean billings and we get all of that. My view of this is that I think the department needs to do a better job of getting the message out to the public as to where the services are available. I think you've seen that you know, we didn't have a great provider list, and that we're trying to fix that, but I think then we also have to go out and it's kind of very much like if you had a restaurant closed and people don't know about that there's a new one that opened on the other side of town, and so nobody's going over there for a while. And so I think we have to do a better job. I think DHS may have to step up and advertise, get out the message to people so that the consumers, that the patients know where they can find those services.
So at this point, it seems like you're saying there's not enough providers out there coming forward to...
I'm saying I don't think that the patients are using all of the providers that are out there. And so I'm not saying necessarily that we have to recruit more providers, but I think we need to make sure that all the patients know what's all available to them so that they can access them. If they don't know what's available, they can't access them, and I think that we were at fault for that. I think DHS needs to do a better job getting that message out.
I don't know that you were at fault for it. You were given something that you didn't ask for based on this bill that passed that basically gutted the perfectly effective program. Now you're scrambling to try and figure out how to get providers to step forward. The Affordable Care Act in Iowa has been an enormous success. The expansion was done in a bipartisan way, as you know. 150,000 people have access to mental health and substance abuse treatment, two big issues in Iowa. Last week, the governor proposed that we should repeal and replace the Affordable Care Act, which would take away mental health coverage and substance abuse treatment for more than 150,000 adults. Do you think that's a bad idea?
You know what, I'm going to tell you this, I don't worry about what's going on in Washington, D.C. I got a lot to worry about.
This happened here
in the state of Iowa.
Here in Iowa.
And so, you know, I'm just going to tell you that whatever happens in D.C., I'm going to make it work here, whatever happens there. And so, I mean, there's a lot of talk about that the federal government may capitate or block grant Medicaid. I don't know what they're going to do. Whatever they do, you know what my job is? To make it work. To make sure that our patients get as much coverage as possible, and that we make it work as well as we can make it work, and that's what I'm committed to, and that's what I'll do. I'm not going to second guess them.
Thank you, Mr. Chairman. Mr. Chairman, the governor is suggesting that we should somehow walk away from the $800 million from the federal government today to provide health care to Iowans would be an absolute disaster for our state. At a time when everybody around this table believes we should need to invest more in mental health. The opioid issue is a huge issue. Substance abuse treatment now for 150,000 people. I would hope that the committee would educate the governor. I assume it was maybe somebody put that line in their speech. You didn't know it was there. But it's a disaster for the people of our state. I hope we can communicate that to her. Thank you, Mr. Chairman.
Thank you, Senator Holcomb. We have 4 more people in the queue, and we have about 10 minutes left. So, next up is Senator Reagan, and then Senator David Johnson after that.
Thank you, Mr. Chair. Thank you, Foxhoven, for being here and giving us an hour of your time. Talking a little bit about what the federal government does and how it impacts us. I'm interested in the S-chip in Waukee. I know you've been a strong advocate for children, and I know you know how important it is. In the governor's budget, I don't see anything, assuming that we're not going to get that. So, do you have a plan in case there is no authorization?
Again, we've been working on a plan if that happens. Right now, we're funded through part of April. Every indicator that I have is that CHIP will be reauthorized. I mean, I last received an email about it this morning where they believe it will be reauthorized. I think it will be. I think that there's strong support for it. I think we're really, really lucky in Iowa that we do have the funding to be able to go through till April, unlike some states. One of the indications that tells me that it's pretty likely that it would be, besides what everybody seems to say, and that it's a good program for kids, that it would be reauthorized, is that when I asked about those states that didn't have money through April and said, how are they doing it? Did they discontinue? I don't know if you know what they're doing. CMS is loaning them the money, which tells me that they expect CHIP to be extended. I can't imagine the federal government loaning states money for their children's health programs if they didn't think it was going to be renewed. And so I'm not putting words in CMS's mouth, but that's a pretty strong indication to me that it will be. And I think it will be just any time now.
Well, I hope you're right. I can't imagine people walking away from children and health care.
Well,
I understand, and I think it'd be unconscionable. And the other thing is, you talked about getting groups together and providers together and trying to understand the problems. Isn't MAC doing that? Don't they have recommendations? Have you been working with them?
Yeah, we have.
They seem to be a group that's set up for that situation and should be giving feedback. I'm just assuming they have.
You know, the first day that I met, the first day that I started work, I believe it's my first, it might have been my second, the first or second day, I went to a MAC council meeting. And the co-chair of that council said, I've got one request from you, and that is, we're required to make recommendations, but the director has never really responded to it. He's never responded back to them. And would you commit that you will respond? And I said, yes, and I have. You know, when they've made recommendations, I have responded back. We really think it's a good idea to really spend a lot of time, not just at a formal meeting, but just rolling up our sleeves with providers and find out exactly what happens in cases for them, and that they can just even refer to specific cases so that we know when coverage isn't there or not. That it isn't in some kind of formal meeting like this, but it's a meeting that's a public meeting. We want to be able to talk about an individual case even if necessary, and to be able to say this is a mistake and this isn't what should happen and how do we fix this. Just as we do right now individually when people contact me or Director Randall by email, we want to do that kind of en masse and look at them and fix all the systemic problems that we can identify.
Well, you probably couldn't discuss too many cases in public with a group together just because of HIPAA. But I would say, I think that MAC Council has been always trying to work toward good things. And so I hope your response is back to them. We're accepting some of their recommendations.
It has been.
It's a large group, and they bring a lot of providers to the table. So I appreciate that.
I do value it.
Thanks.
Thank you, Senator Reagan. Next up, we have Senator David Johnson.
Thank you, Mr. Director. You know, when I walked in the room today, I was under the impression that this was a meeting of the Human Resources Committee, but there have been moments here where I thought it was in the Wharton School of Business. I hear a lot of talk about business. I mean, is this what, is this what we're doing here, Mr. Foxhoven? Being here a long time, 20 years, the Department of Human Services, the important word there is human. It isn't, the emphasis should not be on services, it should be on human. These are people. And then we can go to services. I stopped in the interim, thank you for being here, I stopped in the interim to talk about two things, child protection services and the MCOs. I've been against managed care, the switch to managed care. I think it's a sad commentary that if the federal government says roll over, the state of Iowa is going to roll over twice. To make the state, there's no question that managed care is going to happen. This is no way to be running a government, whether it's in DC or it's here in Des Moines and for the state of Iowa. I can count in my 20 years 5 directors of Department of Human Services. What's wrong there? Why cannot we keep someone for some period of time? I just don't know. But my constituents at every forum I've ever done during the interim are very unhappy with with the Medicaid transition to managed care. I just want to emphasize that again. I'm disappointed that the legislature was left out of this decision completely. What are you going to do to repair that? Because I still feel just a real concern about the administration calling all the shots without legislative oversight.
Here's all I can respond to that. That was 20 months ago, well before I came here. I came here with a direction to do the best I can to make the Department of Human Services human and to serve the people that we serve the best that we can possibly serve them, and I will do that. I'm going to make it work. I believe that we are down the managed care course at this point, and that's where we're going to stay. And I'm going to do everything I can do to make sure it's successful for the people that we serve and for the state of Iowa.
Okay, thank you. Let me just ask a couple of questions about child protective services. What is the caseload right now on workers with child protection services?
I'll give you those exact numbers. I appeared for the committee tomorrow, and I should have that number better at that point. We have higher cases than I think you've ever heard that we've had before. They're cases that we're measuring properly now, and I think they're finally measuring them properly. In the past, I'm not saying anybody was dishonest, they weren't dishonest, but we used a very simplistic method of measuring caseloads. That is, we took people of this job classification, let's say social worker 2 or social worker 3, and we divided by cases, and we said that's the caseload. And the problem is there are some people that are social worker 2s and social worker 3s that don't have caseloads, like the people who answer the phones at the child abuse hotline. And so as a result of that, that made those caseloads look lower than they are, and they are higher than they've been, than I think you've heard from before. It's been harder to get a handle on what exactly is that caseload, and that's one of the things I've asked our people to determine, and they probably have it this morning. They know they'll have to have it by tomorrow. I last asked them at 10 o'clock, do they have a caseload number, But we know the numbers certainly higher than what the national standards are. Now, I don't know that you would apply the national standards to us because we use what we call FSRP workers that we contract with. So our workers are case managers and not directly case social workers who go into the homes. So certainly we wouldn't use the same caseloads, but their caseloads are pretty high. There's no question about it. Again, I'll be in front of a committee tomorrow and be able to give them that exact number, I would think. But they're higher than I would want them to be. But I think our people are doing an incredible job with the caseloads.
Well, maybe we should chronicle what a day in the life is of a caseworker, because you know, I think that's what's important. You say you want to make the employees at DHS that make their lives more livable. Well, you're not in Western Iowa, not from the caseworkers that I'm talking with, or who are talking to me, really. That's the other way around. They're reaching out to me, looking for some answers. I mean, it could be as high as 30. You know, and, you know, and reports are that...
I think there are places where they're higher than that.
Well, okay, there are places, so what's going to happen there? I mean, if they're going to have to work overtime, they're going to be away from their own families. In Western Iowa, we've got windshield time, and you know that.
Right.
And so do they. I mean, so I'm talking about a day in the life when you have to cover a lot of ground, and you care about these children, and you don't want to let go of that. Nor should we. We let go of 2 young girls, and there's things happening all across the nation with this. This is serious business. It's serious business, especially where, you know, let's not get into being a low-wage, low-skill state, but we are. And that puts additional pressure on families. I'm looking forward to seeing what happens here. And I don't know. But anyway, I know there's other questions, Mr. Chair. I appreciate that very much. Thank you, Mr.
Yeah, I would just say quickly in response to what you're saying as well. Again, this goes back to my saying we have terrific people working for us. Our turnover is way less than the national average, way less. It's less than the state average for state employees in general. Our people are really committed to doing a good job. We're asking them to do a lot, and I agree with you on that. But we really have great people who work really hard every day.
But you're asking them to do less overtime, right?
Yeah, I am.
Okay, enough said.
And that's not just for money, that's because I think it's fair to them.
What about the children we're supposed to protect? Thank you.
Thank you,
Okay.
Senator Johnson. Next in the queue is Senator Mathis. And
Thank
then
you,
last is
Chair.
Senator Johnson.
And thank you, Director, for coming today.
Sure.
You are very optimistic. I'm not so optimistic. We've looked at some issues starting in April 2016 that involve releasing patients, providers not paid, reducing services, no services, death, pre-authorization issues, arguments over medical necessity, arguments over transportation and ineffective and inefficient transportation, and it keeps going around in a circle. We keep talking about the same things. One thing, I think, when a provider is under a corrective action plan, that's not good news. And CMS, the Centers for Medicare and Medicaid Services, has put your organization under a corrective action plan.
Because of the lack of choice, because we have to take some of these patients into fee-for-service.
And I don't look at that optimistically. Maybe you do, but I don't think that's a good thing.
Oh, I don't think it's a good thing. They gave us a year to correct it. It'll be corrected within a couple of months.
And so one of the things was making sure that AmeriGroup expands, and the other one was to reprocure. So you're working on both things. I know that we don't want to lose AmeriGroup, or you don't want to lose AmeriGroup, because obviously that would be about choice. And we've seen patients auto-enrolled to WellCare dropped out, then to AmeriHealth, then AmeriHealth dropped out, then they were auto-enrolled to United, and then quite possibly they would be going into this new reprocured insurance company. I'm agreeing with Senator Johnson that are we making their lives more livable by doing this? I don't know anybody on commercial insurance who's had to, since April of 2016, anybody here changed insurance companies 4 times?
How about doctors?
Anybody? Okay, so I think if you could address, you've reissued the RFP.
And that new company or companies would not start until a year from this July.
And Medica and Centene have applied. Medica is now out. Centene is left. Can you tell me if they are still going to go for the business? And since you've expanded or lengthened this RFP process, what are your hopes that you're going to be able to bring another insurance managed care organization here and offer choice and hopefully stop bouncing patients around from insurance company to insurance company?
Well, as I told you this morning, of course, I haven't communicated with Centene because we're in the middle of an RFP, and as you know, if I communicated with them, you know what the rules are, they'd be excluded from it. And so that's what I told you this morning, that's what I'll tell you again right now. The reason Director Randall isn't here today is he's doing a roundtable for basically companies from all over the country to tell them about the Iowa program, to tell them what the RFP entails, to answer questions about it so that we're able to find more companies. I am confident we will find more companies, that we will have 1 or 2 more companies that will join us in a year from July.
But they have not applied as of yet. You haven't seen any other applications under the RFP?
No.
That's all I have.
Thank you.
Thank you.
Last question from Senator Johnson. Great.
Thank you for coming, Director Foxhoven. I will first start, and I'm going to keep this very short. I got a meeting. Everybody's got to get going. I want to say all the issues that you are dealing with, you stepped into it. You got it. It's yours. You own it. I'm saying I'm here also. All of us are. But you know, to put this shortly, parents, providers, nursing homes, hospitals, everybody that's been involved, the concerns I hear most are the expectations were never defined, the funding's late. That's most of that I dealt with is where's the funding and how do we get it, and a path to appeal because those expectations probably were not clearly defined. And so those are concerns I'm just bringing to you. The concern I have is that I heard from some providers, and you know, when I start hearing them talk about wanting to close a door, and these are extremely good people that these providers have, that they do put their heart and soul into it with, you know, their customer. And I want to make it known, I feel like this is my chance to voice for my constituents, is that's a big concern of mine, that we could lose some providers now, but your job is huge. I think we recognize that. Ask me what I can do to help you, and I want to see a good outcome for this because the alternative isn't good for anybody.
I do too, and the providers know that, you know, I've gone out and met with a lot of them, I value them too. We don't want to lose providers.
Can we bring the director back, please, Mr. Chairman?
We can certainly try. And with that, we'll end our questioning for the day. And in closing, I just want to thank Director Foxhoven for being here today. And I just want to say to you that the committee is more than willing to work with you on any issues that you may want to bring to us. And we have one piece of business to handle yet in the committee, and that's to approve the rules for our standing cell vote. All in favor say aye.
Aye.
Meeting adjourned. Thank you very much.